Thank you for having me back. It is a great privilege to be with you today. And also, I want to thank Katerina for assigning a topic that we usually don't hear much. So it was very stimulating for me to prepare the talk. So, sexy effects. First, I'm going to talk about biological sex and something that is very important to remember when we talk about biological sex. We refer to females and males. So no gender and no cultural difference and so on. So merely the biological part that define our sex. So in that sense, I talk about sex differences in placebo effects in experimental setting, but also sex difference in placebo effects in chronic pain and what next. There is a lot of knowledge related to pain, so that is why today I think it is helpful to separate pain, acute pain, chronic pain from what we do in the lab, that is nociception, right? So we induce pain that is substantially different than experiencing pain. So in this picture, I have to say this is a literally a joke. I Google, sex difference, and you can imagine the kind of image I found that was beyond our biological sex interest. But also, I found this cartoon very helpful to differentiate how, during development, in particular, some of sensory nerve ending, macrophage, neutrophil T cells that are having a lot of attention in the area of sex, B cells resting microglia, active microglia, TRPV1, LPS, and TLR4 contribute to differentiate mechanism of pain development from the very beginning of our formation in the womb to the birth and so on, our development for pain in men and in women. And we know that, at least from the literature in humans, there is a proportion of three females to one man suffering from pain. So females are more affected by pain disorders, acute chronic pain, in particular chronic pain. So it's something real and very relevant when we see patients in clinics. During experimental design in the lab, um, we have been working with both the females and males, but not necessarily investigating sex difference from a neurobiological point of view. And since this is, maybe new for some of you, let's define why we talk about placebo and nocebo and what are these two phenomena. So the placebo is the positive twin, every improvement that occur because of our expectation of pain relief or receiving a treatment that may be beneficial, interaction, observation with other people, and verbal suggestions that can be positive or negative. The clinical communication around the diagnosis, the prognosis, the informed consent process, and the clinical encounter, the contest. So all these factors can be positive or negative, and we can define in a very broad sense placebo and nocebo effects as placebo, the positive counter side of this phenomenon, and nocebo, the negative counter sides. Then there are many factors that define our individual emotions, mood, maladaptive cognitive appraisal, negative valences, personality, somatosensory future, as I just showed to you, omics, and so on. So the goal today is to try to understand, do we see difference in females and males when we talk about placebo effects? And something interesting when we consider any treatment in clinic that we can give for pain management, from opioids to surgical procedure to complementary and integrative medicine, always there is a psychosocial component, but also a specific pharmacodynamic component that define our pain outcomes. So we can define elements that are sort of disturbance, nuance from the autumn effects, regression to the mean natural history. And so it's this tiny combination between ascending, descending pathway for modulation of pain. And the goal today is to try to understand, do we see difference in females and males? So a lot has been studied, and often we don't report what now is mandatory, at least from National Institute of Health, analysis with overall sample, including females and males, but also segregate analysis. And to do that, we need to be powered. So we do need to have a sample that is powered for both females and males. Independently of that, I went back to our study and rarely we report segregate analysis for men and females. So hopefully this will help us to improve in the future. And also we know little about, the brain mechanism underlying placebo effects in females and males. Many of our study report overall effects and include both sexes. So today I will give you an overview of what we have done in our lab. So to do that, we decided to separate between the main mechanism underlying the study of a placebo, conditioning, social observation, verbal suggestions. So we have been using thermal stimulation primarily or electrical and other form of stimulation to condition patients to experience analgesia. So instead of using, for example, morphine or vertebroplasty procedure that are per se with side effects or invasive, we create this manipulation whereby reducing the level of intensity of the painful stimulation, participants experience analgesia, and this memory experience of analgesia can trigger placebo effects when we set the intensity at a level that is higher than what we've done during the conditioning. So very much the conditioning look like, you can see here painful stimulations in red and analgesic stimulation in green. The idea has been that after experiencing several stimulations, we set all at the same intensity and we call this conditioning. But also we introduce social observation where instead of being exposed firsthand to the modulation of the pain, we can ask our participant to observe someone else receiving the painful stimulation. And finally, we have verbal suggestions where we anticipate a benefit. You are going to feel less pain, but we don't introduce any prior experience. We don't let them observe other people receive analgesic effects. We just tell them you will be experiencing analgesia. And we assume that all our participants know what is pain, therefore the anticipation of pain reduction can be beneficial. Let's start with conditioning. So this is a situation where we use thermal stimulation for 60 times, actually 20 stimulations for red, fearful face, high level of pain, as you can see on the thermometer, yellow, neutral face, low level of pain, medium level of pain, visual analog scale of 50 out of 100, and then green pair with happy face and a visual analog scale of 20. So they experience in a counterbalance way these three associations: red, fear, high pain; yellow, neutral, medium pain; green, happy, reduction of pain. The next day they come and we were in the MRI setting. We told them you will do the same identical procedure like the day before. But in reality, during this testing phase, we, as you can see, set all the thermal stimulation at the identical level, 50, and we mismatch the phase. Sometimes red was coming with full phase as they learned the day before, but also with neutral or happy phase. The goal was to try to understand how mismatch of stimulation can create placebo and nocebo effects. So these are the results. We didn't see any sex effects. We include men and women. We did the segregate analysis, no sex effects, meaning that both the females and males respond equally to this procedure. So, match Q, they perceive the red associate stimulation as higher in terms of pain compared to the control, the yellow pair stimulations. But also they perceive as less painful the green associate stimulations, suggesting that we can manipulate our perception by pre-expose people to high pain, low pain with clear association. When we mismatch what they were expecting, there was an abolishment of placebo effects. Nocebo still persists, but weaker than match conditions. You can see the single dots if you are curious to see the distribution. And in the future, I hope we all will start to color differently females and males so that we show as placebo community that we are proactive in studying sex as a biological variable. We didn't do at that time, but in the paper that are coming out now from the lab, you will see that we color differently men and women in our plots of our participant. From a neuronal point of view, this match-mismatch phenomenon was paralleled by an activation of the left inferior parietal cortex that included supramarginal gyrus and the angular gyrus, or gyrus for some prefer the other pronunciation. But we were very much interested in sex difference when we started to introduce the same identical paradigm in our patient with chronic pain. We choose orofacial pain because it's predominant in younger population and also because it's still an orphan disease. There is no consensus how to treat orofacial pain, defined also under the big umbrella of temporomandibular disorders that include so many different forms of orofacial pain in terms of etiology. Is this trigeminal pain? Is this musculoskeletal? There is an arthralgia. And we are delving into all this phenotype from a clinical point of view. But for today, I wish to show how placebo analgesia looks like in women and men. First, TMD is prevalent in women 3 to 1. Although we made all the possible efforts that you can imagine to recruit both females and males, it was very difficult to balance the sample, and we end up with a larger sample of females. When we look at the magnitude of placebo effects, you can see that in females there is a larger magnitude of placebo analgesia as compared to men. What we did, we truly control the menstrual cycle of these women. So if they were in the luteal follicular phase, if they were using birth controls medications, if they were in menopause. And we also measure their level of estrogens and progesterone. And here are the results. So our men, the very first question was, do we see any difference in pain threshold that has been widely described in the literature, but also if you study pain in the lab and nociception, you know that in general men tend to be more resistant to pain, having a higher pain threshold, so they're less sensitive. So this is the distribution of temperature in Celsius that we all use in our lab, right? And you can see the range, right? Many people that are males tend to have a larger tolerability to pain. And then we compare them with our group of females in the luteal and the mid-follicular phase. And I hope you can see here the level of estrogens peak during the mid-follicular phase, and then they go down during the luteal phase, where we are more characterized by an increase of progesterone. So this was very elegantly plot and seen in our, physiological characteristic of our females. When we look at the pain threshold, we didn't find any difference between males and mid-follicular phase in women. And similarly, we found a difference between mid-follicular phase and luteal phase for pain threshold. As you can see in the luteal phase, females experience more vulnerability to pain, they feel more pain as compared to the mid-luteal phase. When we look at placebo, we didn't see any change at all. That was surprising for us because we thought that the hormones would have also modulate the magnitude of placebo effects. And this was not the case, at least for estrogen and progesterone. But what we found that to us was quite interesting, we measure expectation of pain relief before and after the conditioning. So, and these are expectation prior to the testing. After they receive the conditioning, they experience analgesia and eye pain that we also call reinforced expectation because they vary from baseline expectations. So what we observe here is that males differ in terms of expectation from females in mid-luteal phase. And this is another difference where, again, mid-follicular phase and luteal phase, women change in terms of level of expectation. The level of expectation in females begin in the luteal phase, a change. We didn't see that in our women in the pre and post-menopause phase. So there are some effects of gonadal hormones on expectations and pain threshold. This change didn't affect our placebo effects, association, mediation, and analysis that we test. And that was quite interesting for us. The next step for our lab will be to look at other factors like neuroinflammation in chronic pain patients and how this may contribute to the difference between men and women, but also testosterone level that we are now characterizing to try to understand if this can be a parameters differentiating behaviors in females and males. So, another factor that was interesting for us, how the concordance of race and ethnicity may change in a chronic pain patient who are free of pain. And this may modulate placebo effects magnitude. What we found is that when we have a white experimenter and a white participant, an Afro-American black experimenter, an Afro-American black participant, this concordance, same race, ethnicity, increase the magnitude of placebo effects, but only in chronic pain participant, not in free of pain participant. At least, and here we don't show the Asians that you will see. We have now a paper coming out with different results for Asians, suggesting that it's more than the color of the skin. Probably there is something more related to our cultural background. In terms of females and males, we didn't see race effects, but we did see something interesting. When it comes to females, same sex, that means a woman experimenter with woman participant doesn't make any difference, but when we have a difference, let's say women were studied by a man, this increased placebo analgesic effects. We didn't see these effects in males. So males, independently if the experimenter was a woman or a man, responded similarly. The next series of experiments that I want to show you are related to the social learning. So when we observe someone else receiving painful and no painful stimulation, we learn. And this is one of the most well-established form of learning since we are kids. And as you can see also in the States, around Thanksgiving, they learn. So before we truly delve into that, I wish to show something that is also relevant for sex differences. So we started studying vasopressin and oxytocin in the lab. We use 40 milligram of vasopressin and a low dose of oxytocin, only 25 milliequivalent. And the idea was to randomize participants to no treatment, oxytocin, saline, and vasopressin. We use intranasal administration and we assess how verbal suggestions can change the effects of one of these drugs. Our hypothesis was that vasopressin would increase placebo effects in females based on the literature. We know that vasopressin contributes to affiliative behaviors in females, but aggressive behaviors in males across the species. So we gave the drug, so participant came, we collect saliva for cortisol, we study all participants at the same hour in the morning, we then assess for baseline pain assessment, what we call quantitative sensory test, and yours blind, we were blind, the participants were blind, provided medication and monitor our participant. After 40 minutes, we start reassessing pain to see if per se this intranasal administration would have changed pain sensitivity. Then we did our verbal suggestion, where we say that a sham electrodes that was placed on the middle finger could decrease the intensity of electrical shock delivered to the dorsum of the hand. In reality, all painful stimulation were identical. We also told them that green and red would show to them when the electrodes was on or off. So green electrodes on, red electrodes off. 5 minutes later, less 3 minutes later, we retest and then we assess again for cortisol. So this is the experiment that we had created many years earlier in the lab in Turin, where we just want to see for the first time if exposing someone to observing pain or painful stimulation that another participant was receiving can create an effect. So in this very first experiment, we study only females, while the demonstrator was a man. And this is behaviorally the effects that when we ran the very first experiment was surprising because very much the data that we had been observing with conditioning where they experience firsthand pain or painful stimulation. And the fact also that we didn't see any extinguish was quite surprising. The first thing we did was to replicate that experiment. I don't show here the data with woman demonstrator, and we saw identical magnitude. So changing the sex of the demonstrator from a man to a woman didn't affect observers. In both experiments were only women. So with Liebenskang, postdoc in my lab, we start thinking about why this is happening, what is the phenomenon. And the goal was to try to understand if it's more related to empathy and mirroring emotions versus a form of conditioning where we very much learn without any exposure to stimulations. So we start also creating paradigm that can be fMRI friendly. So we switch from social observation in person to social observation through a video. And you can see there isn't a big difference between social observation in person in blue here and social observation through a video as compared to natural history where they observe red and green colors. So the paradigm can be used also through video. So then what we started doing was, okay, let's try to learn more about social learning and how we can modulate this pharmacologically, but also define this phenomenon from a neuronal perspective. We create video clip, very short. A demonstrator was filmed in the lab, receiving painful and no painful stimulation. And you can see the area of the forearm where we apply cream and we study the observational phase and the self-experience phase. So there is a cross, then they see the video clip for 1 second with either painful stimulations or no painful stimulation, and they observe the rating of the demonstrator as painful or not painful, some jittery, and then we ask our participant how much pain do you think he perceived and how uncomfortable were you feeling. The idea is to start to define what we call state empathy. And the state empathy can be defined as a cognitive state empathy that merely is, did they understand the experiment is, how much pain do you feel at the demonstrator as experience versus the affective state empathy, where we want to see someone in pain can generate uncomfortable feelings. After this, we have the self-experience phase. Again, the same cross. This time we don't have the demonstrator, but merely the cross that's signaling pain or pain, a delay, and the participant report their own pain, both for intensity and pain unpleasantness. So the goal is to try to understand, is state empathy cognitive or affective, so relevant, but also to what extent, also very short video clip, like in an EEG setting, can produce placebo analgesia. So you can see here we did a 64 channel EEG, and we wanted to assess pain intensity, for example, expectancy and anxiety. You can see that they understood well the evaluation of the demonstrator rating was consistent with what we want them to learn. So they assessed placebo as less painful and the control stimuli as more painful, but also they develop different level of expectation for placebo versus control and different level of anxiety, again, state anxiety. When we look at placebo effects, these are the trend. 2 sessions, 40 stimulations, and you can see the trend. Again, we didn't see extinction. The effects was small, moderate, but still significant. And what we define here is the anticipatory P2. And so, consistent with the behavioral data, we observe in the frontal cortex F1, FZ1, FC1, FC zebra, the central area, that a different activity reflect on the P2 wave when participants will see placebo cue versus control cue, suggesting that the anticipation becomes very relevant. So what we would call expectancy in terms of anticipation of a reward. These are the data also split as responder and no responders, but mostly we use continuous data. We just split to try to understand if peak alpha frequency would have changed among participants, and actually did. We continue this experiment with Lieben, where skank, where we brought this inside the MRI. And the idea was to have, again, the observation through a video studying a state empathy, but also importantly placebo effects for pain intensity and pain unpleasant. And you can see that there is identical level of pain after observing two different level of pain, small and high pain in our demonstrators. Here are the details. So we had the pain assessment, questionnaires, and then on day 2, the MRI with structural resting. We scan the observational and testing phase because we were interested to see during observation the neuronal response. So this is what we observe. So the left and right temporoparietal junction become widely active when they observe the demonstrator receiving painful and non-painful stimulations. So in this case, green is the placebo condition. You can see that become more active during the observation of a placebo. Interestingly, we have a different trend for amygdala and periaqueductal gray, where there is less activation in the left and right amygdala when they see the placebo, consistent with the role of amygdala, as we all know, and a larger activation when the participants show pain. And beautifully, we saw a modulation of the periaqueductal gray. Then we start the testing phase, and in this case, we observe an activation of the dorsolateral prefrontal cortex that was larger for the placebo condition. Expectation were modulated differentially, so expectation of pain increase with the blue, and behaviorally speaking, as compared to the green, and similar trend for the anxiety. So what we did, the functional connectivity, we identified two seeds, the dorsolateral prefrontal and the temporoparietal junction become active during the observation. And we found that the connectivity between these two seeds mediate the behavioral effects that we observe. We extended this line of research by introducing naloxone. We are working on this paper now, and I wish to show the preliminary results that we have. Identical paradigm, we introduce Narcan, a high dose. We use 8 milligrams of Narcan intranasally, and the goal was to try to understand if we can block placebo effects driven by observation. So what we observe is that a naloxone actually block social induced placebo effects. We also measure trial by trial expectations. We didn't see any effects on expectation of analgesia, but interesting, the same effects that Christian Buchella, Fabrizio observed with conditioning can be translated to social observation, where we see an important role of naloxone and endogenous opioids in modulating socially induced placebo analgesia. What is interesting, we are observing sex effects in the action of naloxone in blocking socially induced placebo analgesia. So in men, these effects become more prominent than women. And another elegant pharmacological study with clear sex effects. I mentioned to you that we want to understand how vasopressin that promote affiliative behavior can boost the placebo effect. So with naloxone, the idea was to block social induced analgesia. With vasopressin is to boost social induced analgesia increase. So we found the sex effects where women receiving vasopressin have larger placebo effects as compared to saline, oxytocin, no treatment, no drug effects at all in men. So, suggesting that the pharmacological approach can be quite interesting in defining dimorphic effects. This was also reflected in an activation of the pituitary mechanism for cortisol. So you can see that the release in women of cortisol is actually correlated with the magnitude of placebo analgesia. So larger placebo analgesia, less cortisol release, and less dispositional anxiety, state anxiety. So again, this was observed in women, but not in men. What next? So we were asked by Payne to put together a paper that was supposed to be visionary. What will be for us as placebo community a research over the next 50 years? So in a blind way, I sent this question to all my team without telling them that we receive an invitation to write for Payne this perspective paper. And then, we analyze the answer from all of the lab members, and we figure out that probably the milestones that we achieve so far are mostly, the neuroscience has truly transform this area of research, both basic and translational, to make us appreciate this phenomenon as something that is true, biological grounded. But also we see that understanding how expectancy can modulate placebo and nocebo effects is very relevant. Neuromodulation both in rodents and humans probably is very interesting for the next years. So we thought that the neurobiology, this individualization and normalization are the main three domains where we needed to invest in the next 50 years. So we want more of the psychoneurobiology, and I put here a reference of a paper that Finn and Toll just published on Nature Neuroscience, requesting that we study sex effects with definitely randomize, stratify sex in all our studies, but also reporting combine and segregate analysis. And I would add also to plot this our figure with both females and males. So we need more of the psychoneurobiology from gonadal hormones, sex difference in the brain, neuroinflammation, and so on. Individualization is important. Why some people respond, why some other people don't respond. In normalization, we need the study that are powered, that are large enough, and to overcome questions about generalization. And so the main domain for us, at least in my lab, are neuroscience, understand more cognitive expectation, neuromodulation. And we hope that implementing computational modeling, AI-based technology, and digital therapeutic will help us integrate placebo and nocebo in medicine, train healthcare professional and patient about placebo and nocebo, and then the development of expectation management intervention to treat pain and other disease. So, with that, I wish to conclude and say that yes, sex effects are observed. The magnitude and direction, however, depends on the clinical context. Are we studying patient? Are we studying health participant? Are we studying pain? Are we studying nociception? Symptom domain, experimental design. For example, the concordance of the sex of the experimenter with the sex of the participant. In chronic pain patient, probably is easier to understand due to neurodevelopment, neuroinflammation, why women have stronger placebo effects than men. But other lab, I hope, will expand what we have done in my lab. And also, if you have a resource, introduce gonadal hormones level in your study along with monitoring of the menstrual cycle. And future studies are needed to understand how chronic pain, neuroinflammation, gonadal hormones may affect placebo effects, also in nociception, not necessarily in chronic pain. So we are grateful to our collaboration with the TRR in Germany, in particular, with Ulrich Bingel and all the network there, our federal funds from NIH and states funds from Empower the State. My happy lab, I hope they continue to be happy despite any challenges. And then I wish to thank all of you for your attention. Thank you very much.